Hi, everyone. Thank you for coming and to our very first seminar slash webinar. I'm Kwan, CEO of Enable Exercise. And before I introduce our speaker today, I would like to acknowledge the traditional custodians of the land and pay respects to their elders past and present. I also want to say welcome to you guys that came in person. Welcome to our clinic. So this presentation, we'll be doing a seminar and webinar. So for people that are here for the seminar, the toilets are on either side of our clinic. And also obviously light refreshments are ready there as well. So during the presentation, we will have time to have questions and answers as Q&As. For the guys that are on our webinar, if you want to just raise your hand or type the comments, the questions onto the comment section, we'll be able to answer that. And get Rhianne to answer that. If you guys do have any questions in regards to this presentation after today, we'll send Rhianne's details as well to you guys, so you can send an email to her directly, or you can send it to us through Enable Exercise as well. So before we get started, just make sure everyone's phones are on silent, and for those guys on our webinar, just make sure that you're staying muted as well, just so we don't have any distractions for the webinar. Thank you. So Enable Exercise, I'll give you guys a little introduction about us. We are a specialized neurological rehab facility. So we not only provide highly tailored and high quality exercise programs and movement therapy for our clients, but we also want to drive this community and the field of what we're working with. So we want to make sure that this seminar here would be one of many that we can continue to share our knowledge and move and improve the quality of our service to our clients as well. Cool. So a little bit about Rhianne. She graduated her Bachelor's of Exercise Science back in 2012 at University of Sydney, and she completed her Master's at ACU of Exercise Physiology in 2014. She's always had a passion for neuro rehab, and she started working at Enable Exercise in 2019. So now she's our clinical standards coordinator, and she regularly provides training for our staff on an ongoing basis. She also completed her graduate certificate for neuro rehab as well in 2020, and she has a lot of other experiences with MSK, aged care, rheumatoid arthritis, and many other things as well. So she's a wealth of knowledge. So she generally loves to exercise as well, and regularly runs marathons just for fun as well. So that's a little bit about Rhianne. So without further delay, please help me welcome Rhianne.
Hang on, I might just make this a bit lower. Okay, welcome. So thank you, Kwan, for the introduction. And today, just going through a presentation on exercise for those with spinal cord injury. So going through a few learning objectives to start off with. Basically, want to make sure that you all know exactly what a spinal cord injury is to start off with, and knowing and understanding the contraindications and considerations when working with those clients. I'll give a bit of a summary of the current research on exercise and a few of the kind of key concepts that are happening in, I guess, the new emergence of therapies, and talk a little bit about neuroplasticity in the context of spinal cord injury, and then going into the difference between different approaches in therapy and how they relate to the exercise prescription, how to maximize client outcomes, and some training tools for different types of training, resistance, cardiovascular, and flexibility for spinal cord injury. So to start off with, we'll go through what you need to know. So we'll go through what is a spinal cord injury, key facts about the spinal cord injuries, and types of spinal cord injuries, and a little bit on the Asia impairment scale. So the WHO definition, it refers to damage of the spinal cord resulting from trauma or from disease or degeneration. So symptoms of spinal cord injury depend on the severity and its location in the spinal cord. So depending on where someone actually has their level of injury, it's going to impact their ability to function. And the symptoms may include partial or complete loss of sensory function or motor control of arms, legs, and or body. So that's just a bit of a summary and a definition. Key facts, there's a lot of people in the world with spinal cord injury. There's between 250,000 and 500,000 people suffering each year from a spinal cord injury, a new injury. Majority are actually preventable causes such as road traffic crashes, falls, or violence. And people with a spinal cord injury are 2 to 5 times more likely to die prematurely. So it's actually really super important that we maximize our outcomes for these clients to make sure that, number one, we try and increase the ability for them to increase their life, but also to make sure that we maintain the quality of life for those that have a spinal cord injury. And as well as that, from an economic perspective, spinal cord injury is associated with lower rates of school enrollment and economic participation. And it also carries a lot of individual and societal costs. So I think anyone that's worked with a spinal cord injury client can probably recognize that there are a lot of other things going on besides the paralysis or besides the impairments that are happening on a physical level. And so I guess being mindful of that as you work with those clients. Bit of a summary of the nervous system. Spinal cord injury is part of the nervous system. Central nervous system comprises the brain and the spinal cord. The peripheral nervous system is essentially everything else. So you see a diagram there. You've got the brain, the spinal cord in the pink, which is the central nervous system, and you've got the peripheral nervous system in the yellow. Effectively, damage to an area of the nervous system will affect the body's ability to move, breathe, see, think, function, and basically anything to the extent that it is affecting that area, depending on the area damaged. Types of spinal cord injury, you've got your complete and your incomplete, basically. So you've got completes, they have a total loss of function and it's bilateral. Incomplete, some function remains, and function refers to motor or sensory. And the brain and body can potentially still communicate through some pathways. So the Australian Spinal Cord Injury Association is a common scale that we use. So it's the Australian Spinal Cord Injury Association impairment scale, and it's basically a grading system for the severity of spinal cord injury. So this is a bit of a summary of the scale, but essentially your A is your incomplete. And as you move down the grade, you actually have more function or more sensation depending on what's happening with that person. So a grade A, they're not going to have any sensory or motor function below basically the level of the injury. And then at your D's and E's, you're kind of looking at a maintenance of motor function, but you might actually have no sensory dysfunction at an E. So effectively you're walking around and you're normal. Whoop. This was just in there just so you can become aware of the different levels of the spinal cord injury and how the motor, sensory and autonomic systems are all affected through the level of injury. So you can see that in the cervical level, you're having quite a lot of sensory and autonomic functions affected as well. So if you have an injury at the cervical level, chances are there's quite a lot more happening in terms of motor, sensory, autonomic than there is down lower. Not to say there's not, it's just there's a hell of a lot in the initial kind of components of the spine that regulates what happens in the entire system. All right, so going into what you need to consider. So we're going into some considerations that you need to be aware of and I guess change things potentially when working with these clients. And a lot of them involve, I guess, impairments related to the spinal cord injury directly. So what you need to consider is the bowel and bladder, sensation, spasticity and tone, contractures, cardiorespiratory system, autonomic dysreflexia and bone mineral density. So to start off with, bowel and bladder, most clients have issues with voiding, sensation, control, etc., and they might use a catheter. So for those that don't know what a catheter is, effectively it's a way that they can maintain bowel and bladder function and voiding when they don't have that ability physically themselves. So the severity and level of injury will influence the effect on the bowel and bladder. Almost all individuals with a spinal cord injury will have some degree of difficulty with one or both of these areas. And there's a lot of psychological effects. So I guess it's a huge loss of stress and anxiety for many people with spinal cord injury. And most have routines that are actually really quite stringent on managing their bowel and bladder throughout, I guess, their life. And I guess being aware that if you're working with an individual with a spinal cord injury, you might have to accommodate some of those needs in a session or in your environment. So making sure there are bathrooms available or making sure that they have the opportunity to utilize a bathroom prior to the session, or you're managing what positions you're in. So some clients actually don't like being in a forward flex position because it can actually put a lot of pressure and they don't have continent control. So it can actually be quite stressful for them in those positions. And so they might also have to control some of the fluids and the foods that they eat around that time as well. So I think it's just important to consider that it's something that they actually are quite particular on. And it's important for us to understand what they might need and how we might need to assist. Alongside that, the catheters and the type of catheters. So it's important to know what product or device that the client is using for bladder and bowel, as it can actually directly affect what you're doing in a session with them. So for example, if you've got a client with an indwelling catheter and a leg bag, you might actually need to check to make sure that that isn't overfilling, or that you actually might have to have the opportunity at some point during the session for that to be emptied. So if it isn't emptied, it can result in a lot of complications. So just being mindful of that. And with something like an SPC, so a suprapubic catheter, making sure that you're not kind of putting pressure on the area or pulling the tube or putting them in compromising positions where it can become quite dangerous in a way. So yeah, and then in terms of the prevalence, it's actually super high prevalence of UTIs in spinal cord injury individuals. On average, is about 2.5 per year. So this is actually something that's, you know, quite stressful. I don't know if anyone's had a UTI, they're not pleasant, but if you're in a chair and have compromised kind of ability to do bits and pieces in your life, it's definitely something that, you know, is, I guess, just not nice. And also the use of medications as well as that. So you're going to have, you know, your antibiotics, potentially ongoing issues, ongoing treatments for that. So there's also evidence that UTI can increase the prevalence of spasticity in clients. So being mindful of that as well, that if someone has got a UTI, their tone and spasticity might be up at that time. Sensation. So sensation is going to be dependent on the level of injury. So you need to think about the skin integrity. So a lot of the time you might be putting a client in a position, or there might be a transfer occurring that basically you might be compromising their skin integrity. So if you were to slide someone across the seat, you might actually be creating a lot of friction across the skin, and just being mindful that, you know, they might not necessarily be able to feel that. So if you're doing that repetitively throughout the session and they haven't got great skin integrity to begin with, you could potentially placing them at risk of a pressure sore or a burn or something like that. Temperature control. So again, the level of the injury is going to impact the ability of the individual to control their body temperature. So it'll be to do with circulation as well as temperature sensation. So being mindful that in situations when you're working with those with impaired sensation, making sure the environment around them is actually comfortable. So if you're cold, chances are they're more cold. If you're hot, chances are they're more hot. So just being mindful that you need to be able to look and see if you feel that the skin is actually cold and, you know, not feeling like it was something you would like to be experiencing, then potentially just creating a different environment around them to ensure that they're okay. Pressure sores can be really, really nasty. So I guess if there are pressure sores, trying to keep pressure off them, but also prevention is the best kind of situation in regards to pressure sores. So if you're putting someone in a position and they're resting against something and they don't have great sensation, you might actually be placing them at risk of a pressure sore. If their heel is on the back of their wheelchair, the footrest, and actually impacting slightly, it can actually be quite detrimental. So I guess doing skin checks is really important. But as well as that, just making sure you as a practitioner aren't placing someone at undue risk. And I guess in terms of sensation as well, you've got your electrical stimulation. So a lot of us in practice use the neuromuscular electrical stimulation. It can be contraindicated quite a lot in those with spinal cord injury, mainly because if they haven't got sensation, there is a risk of burning the skin. However, there are precautions you can take, and just being mindful that if you decide you're going to increase the amount that you're actually putting through the stim, even though someone can't feel it, it's still going through their body. So I think just being mindful of how high you actually do it and making sure that you're not actually going beyond what is reasonable. Okay, spasticity and tone. So I guess the biggest differentiation here between spasticity and tone is that tone is the resistance of muscles to passive stretch or elongation, and it's the resting tension in a muscle. So for those that have lower motor neuron lesions, they're going to have no tone. They don't have any resting muscle tone. For those with upper motor neuron lesions, for those with stroke or spinal cord injury, they're going to have some resting tone in their muscle. Spasticity is slightly different. It's a velocity-dependent sudden resistance to passive stretch. So with tone, it's basically how, I guess, actively tight someone is. And with spasticity, it's how actively tight someone is that resists the movement you're trying to create with velocity. So spasticity can actually be quite helpful. So we have quite a number of clients that use their spasticity to actually help themselves stand up or to transfer. So for example, they can trigger a spasm in their leg, and then that'll help them to get a legs up transfer with a slide board. But also we have actually had a lot of clients where it can be a hindrance. So it might create issues in terms of positioning. They might actually come out of their wheelchair. So a lot of the time they have to be having seat belts. And it can actually just be quite frustrating for the client when they kick in and they don't have that much control over their body, and they can be painful. So I guess they can be affected by meds, UTIs, infections, etc. We'll go into spasticity a little bit more in a minute. But I guess the biggest thing around spasticity is that you need to consider the speed at which you're doing the exercise or moving the joints passively. So because it's velocity dependent, if you're moving someone, say if you're going to stretch someone, if you move them quite quickly into the stretch, chances are you're going to hit some degree of spasticity quite early on in the piece. If you move quite slowly, you can actually kind of gradually increase the stretch without having that spasticity kick in. So unfortunately, it can be a bit of a limitation in terms of cardiovascular exercise. So if you're trying to increase someone's speed at which, for example, they're doing an arm ergometer, if they kind of are doing it quite quickly, they might have a point where the spasms sort of kick in and they therefore have to get a little bit stuck in their joint mobility and range, and they get a little bit limited in that respect. So it's hard to get the cardiovascular response. So contractures, so a little bit different to both of the spasticity and the tone. So it's a limited joint range of motion and deformity that is not able to be overcome by force. So essentially it's a fixed range in the muscle or a fixed length in the muscle and the soft tissue. So it's physical shortening, and it can be a big limitation in sessions regarding to positions that are available to a client. For example, you might have a flexor contraction in the hip flexors, but if you were to try and get someone then in a prone position, they're going to struggle to get fully into prone because their hip is going to be flexed. So it's something to consider, particularly for those that you want to try and get in different positions. It can significantly limit your capacity to get them into those positions in the first place because there is a physical limitation. A little bit on the tenodesis grasp. It's actually an intentional contracture in the wrist and finger flexors, and it's utilized in a lot of clients or individuals that have a cervical spinal cord injury. And the idea is that it potentially can create a functional grasp. So if you look in the first picture, you've got the hand going down, but then upon the wrist extension, the fingers flex and the thumb actually adducts in. And so it creates the ability for someone to pick something up. So in this case, don't try and stretch out the finger extension. Don't try and stretch it out. Don't try and create more range, because that's going to impact the functionality of that grasp, and it's going to impact the functionality of that client to do what they need to do in everyday life. So cardiorespiratory function. So a level of spinal cord injury directly impacts their cardiorespiratory function. In the level of C3, 4, 5, it affects the diaphragm. Anything above that, you're likely to need a trachea tube to be able to, and a ventilator to help you be able to breathe. It may directly impact the innervation to the heart and lungs. So as you probably saw in the diagram before, in the autonomic nervous system, different levels of the spinal cord actually help to innervate the heart and lungs. So depending on the level, you can actually have direct impact on the capacity of the heart and lungs to contract and to work effectively. And then alongside that, you've got the consideration of the accessory muscles for breathing. So for those that have potentially an impacted diaphragm, they also might have impacted accessory muscles for breathing. And so it limits their ability to overall use their body to help them to breathe. So even for those that don't have the diaphragm affected, as a compensation mechanism, a lot of people and a lot of even individuals that haven't got a spinal cord injury will use their accessory muscles for breathing to assist, to help to move the rib cage to allow the lungs to inflate further. So for example, you're going to have people that happen to use the muscles in the neck to try and lift up the rib cage to create more space inferiorly. And so it can help to create a bit more inflation capacity for the lungs. If you don't have those accessory muscles working, then it can inhibit the ability of the body to kind of compensate for that. And again, blood pressure is affected following spinal cord injury. It's impacted due to posture, the cardiovascular system being potentially compromised in the first place, skeletal muscle pump, and pooling due to lack of circulation. So there's lots of different things, and a lot of the time positions that you get a client in is going to be impacted by the blood pressure as well. So you might have postural changes in the session that have an effect on the blood pressure, which someone might have to have. Say if you try to get someone on a standing frame, you actually might have to slowly increase the tilt and not just bring them up to completely upright, because their body actually can't accommodate for that change. So the blood pressure needs to kind of be able to kind of come to the party in regards to catching up with what pressures are placed on the body. Another thing is that you may not actually get your heart rate up enough, or they might not get the heart rate up enough to elicit the cardiovascular response. So there's actually a bit of evidence to say that it's more peripheral changes that can limit, or peripheral mechanisms that limit cardiovascular output in those with spinal cord injury. So for example, if someone's really quite weak in their arms, the weakness in the muscles is going to be the first thing that's going to stop them from getting their heart rate up. Does that make sense? Yeah. And so I guess being mindful that the mechanism you use, the mechanism you use to try and, or the training that you use to try and get the heart rate up can actually impact how effective you are in what you're doing, depending on how their blood pressure and the cardiorespiratory function is working in the first place. And just a side note as well, some new research is coming out to indicate that the MET equation, so the metabolic equivalent equation that we all kind of know and love as EPs or health professionals, it could actually be different in spinal cord injury, and there's suggestions that it can actually overestimate or underestimate, the demand on individuals with spinal cord injury in terms of that. So for example, I might be working at a MET equivalent of 4. The MET equivalent of 4 for a spinal cord injury client might actually be dramatically higher depending on what's happening. So just something to keep an eye out for, and I guess be mindful of that what you think is actually happening may not quite be reflecting what the individual's experiencing and what their body's going through. And something that is, I guess, another reason that we should be doing more cardiorespiratory training with clients is that individuals with spinal cord injury are predisposed to cardiovascular disease. So they're at a much higher risk of developing cardiovascular disease. So I think it's important to address all the manageable and the controllable risk factors, i.e. cardiovascular fitness, and other things like weight and diet and everything like that, just to make sure that, we can minimize their risk. Just quickly on autonomic dysreflexia, it is a life-threatening and a medical emergency. So for those that are spinal cord injury above the level of T6, because of the effects of the autonomic nervous system, sympathetic and parasympathetic, it can actually create what is effectively an abnormal response to what is perceived to be a noxious stimuli. So common triggers are a block in a catheter bag, or potentially a misposition of an ankle, like the ankle might be slightly out of position, or there might be pressure on the skin. There can be a number of other reasons. It often dissipates if you remove the source of the problem. So if you unkink the catheter bag or you remove the pressure, often it will dissipate. However, if it doesn't, don't lay them down, keep them upright to make sure that there's not too much of a dramatic shift in blood pressure, but also They might have a nitrolingual pump spray, which can assist with managing it, but if not, it's a call 000. Most clients will actually be aware of what their triggers are and also be aware of how they should manage it. So I guess take in what the client has to say, but it is a serious matter, and just be careful that you're not creating scenarios at which they're placed at risk. Bone mineral density. So individuals with spinal cord injury have a lower bone mineral density than controls in the research. So it reduces as time continues following the onset of the spinal cord injury. So as the longer someone has had a spinal cord injury, the lower their bone mineral density will be. High risk of fracture, and many are considered osteoporotic. So it's important to consider transfers, positions, loading, the impacts you're using in sessions, and really they should be getting clearance or have bone mineral density scans prior to you actually commencing any loading throughout your sessions. Quick summary on what the research says. So we'll go through a few of the kind of key exercise modalities and I guess things that pop up a lot in sessions and that are common complaints with spinal cord injury. Locomotor training, it's actually used quite a lot, but unfortunately there's inconclusive results in the literature. There is some kind of conflicting results, but effectively there's no statistically significant superior effect of any locomotor training approach on walking function after spinal cord injury compared with any other kind of physical rehab. So there's insufficient evidence to suggest that one type of training improved walking function as opposed to another. There's a lot coming out with robotic-assisted locomotor training. The evidence for that and the effects of that is unclear at this point. And I guess the biggest thing that is shown in the literature is an improvement in gait speed during body weight supported treadmill training is not functionally significant, i.e. a lot of the time the studies actually include people that are not walking. They do an intervention where they do locomotor training. They might improve in the locomotor training, but then effectively they're still going to not be able to walk at the end of that. So it's kind of an important consideration to make that, yes, they might get better at walking in that scenario. However, in terms of the function of their everyday life, they might not actually have any real change. They're not going to be magically able to walk again. An improvement in, and I guess consider the clinical application and logistics. I know a lot of clients are actually really all for locomotor training. There is some evidence to suggest that it can be effective. However, it's the amount that you actually need to be doing and the logistics involved is quite a lot. So you need a pretty committed client and potentially a lot of funding to be able to allow for someone to do what's needed to elicit enough of a response to be meaningful. So a lot of the research is sort of saying several hours a week, several days a week over a long period of time as an intensive is what's helpful. But I think a lot of clients don't have the physical means. They don't have the financial means. And, as a clinic, you might not even have the ability to do that or to logistically make that happen. So I think it's important before you decide, I'm going to do locomotor training, making sure that it's feasible. Neuromuscular electrical stimulation. So it can increase the voluntary strength of paralyzed muscles. So this is where you're applying an electrical stimulation to a paralyzed muscle or a muscle. The difference between that and functional electrical stimulation, so a lot of the time it is used interchangeably. It's not exactly correct. NMES is direct application to the muscle, so external, but FES is functional electrical stimulation. So it is NMES plus a function associated with it. So effectively, you've got your ability to just contract a muscle, or you've got FES, which is the ability to, say, use your legs to use a bike in a functional way using the electrical stimulation. So two different kind of things that I think is important to differentiate. There's no strong evidence that NMES is superior to other treatment in spinal cord injury, but it can assist in motor relearning. The important thing with the motor relearning is that the person has to be active in the process. So if you're expecting I guess, a central change. So if you're expecting, neuroplastic change to occur, you need the person to be cognitively engaging with what you're doing. So there's no use to just sit there, put a stim pad on someone and say, yep, cool, let's hope that this works, get you stronger, get you better at using your arm. They have to be consciously adding to that process themselves and cognitively engaging with it. They need to be able to go, okay, I'm trying to do this, so that there's neural output going into what's actually happening. There is some theories that it can reduce spasticity, and this is due to disynaptic reciprocal inhibition. For example, if you've got really, really high spasticity in your bicep and you stim your tricep, in theory, it can help to reduce spasticity. And it can help to maintain the muscle integrity. So effectively what you're doing is creating contraction. And if you want to make sure that someone's muscle is still maintaining the ability to contract and the metabolism, metabolites, all that within that, then it can help to maintain that if they have the capacity to do so. Spasticity management. So Botox is one of the most common treatments. Studies suggest that it decreases in at least one. Unfortunately, an improvement in the modified Ashworth scale doesn't always mean an improvement in function. So I guess there's that caveat to that. And it does have very variable results. Some of our clients, or some clients that we've seen in the past, absolutely swear by Botox, think that it's helped them a lot. Others are very nonchalant about it. So it really just depends on the individuals and the factors that are contributing to what's going on in their body. Baclofen is a medical treatment, so it's a medication. It's known to be quite effective, but it has side effects. So a lot of clients are non-compliant purely because the side effects can be quite dramatic, but it can be really effective. However, as an oral medication, it acts globally. And so you can't specifically target exactly where you want to have the baclofen effectively working. So I guess being mindful of that. And for clients that particularly use their spasms for assistance in their, say, their transfers and everything like that, baclofen could potentially inhibit their capacity to function. So if they start taking baclofen orally for, say, their arm, but they use their legs a lot for transfers and they use spasms in their legs to help them, can't guarantee that one's going to be preserved and the other one isn't. So it's a bit of a tricky one for some clients to navigate. And there is actually some recent research saying that baclofen can have some neuroprotective effects. Watch the media for that. And then in terms of exercise, unfortunately, the data is inconclusive and there's lots of varying responses to exercise in regards to spasticity management. So basically the current, I guess, guidelines for spasticity management lie within the medical kind of management field. Particularly with the Botox and the baclofen. There are other medications out there. There are other treatments out there, but these are the two kind of primary ones that have been used. Stretching. Okay, so in terms of stretching with spinal cord injury, there's a huge variability in dose in the research. So anything from 24 minutes to 24 hours, 20 minutes to 24 hours. And it really doesn't seem to have found a magic recipe of how long you need to stretch for to have a meaningful effect. The clinical importance in some literature potentially is 5 degrees, while others say it's 10 degrees. So whether or not there's actually anything functionally significant about that is kind of a bit different as well. But there's no agreed upon consensus as to what functionally is relevant, but also what the magic number is for how long you should be doing it for. So there's quite high evidence, moderate to high evidence that stretch doesn't have a clinically important effect on joint mobility in people with neurological conditions. However, from, I guess, a biomechanical perspective, if someone's number one, if they want to stretch, cool, we'll stretch. But number two, if someone is in a position for a very long time and suddenly they're out of that position and they're in that different position for a period of time, then in theory, you would think that that would reduce the risk just purely because they're not in that same position for a long period of time. So I guess, yes, the research says one thing, but you could justify in your clinical reasoning that, you know, them not being in that seated position for a long period of time and being in a different position might help to reduce the impact of, you know, shortening contractures, everything like that. but the research is sort of saying that it's not effective for the prevention and treatment of contractures. For treatment of contractures, because it is a physical shortening already of the muscle and the soft tissue structures, stretching is not going to be effective. It's a structural shortening. Clinical application, I guess it's one of those things that we sometimes choose to do, sometimes don't. A lot of the time, to be perfectly honest, a lot of clients request it. A lot of clients feel it is quite beneficial for them. And so I guess in that respect, it's potentially, I guess, just enough to be able to do it. But then the other side of things is if you're stretching purely to achieve a range of motion that you're going to be utilizing through that session or through those exercises, then that is a good reason to be doing it. So if you want to increase a certain range of motion to be able to create a certain movement pattern or to work a muscle within its full range, stretching is going to be the opportunity to open that door to then be able to work that muscle through the range. Resistance training. So there are significant improvements in maximum strength, local muscular endurance, power, and muscular isometric voluntary contraction in people with spinal cord injury. Basically, the consistent evidence in terms of the consensus for what you should be doing is 2 to 3 times a week at 50 to 80% 1RM. Any form of exercise that overloads the muscle will result in increases in muscle strength. So effectively, a lot of the research is sort of looking at that progressive resistance training sort of approach for those with spinal cord injury. Cardiorespiratory training. So again, the guidelines sort of point at for cardiometabolic health benefits for those with spinal cord injury, they should be engaging in at least 30 minutes of moderate to vigorous intensity aerobic intensity exercise 3 times a week. So it can be difficult to get the output desired to have the cardiovascular benefit. Number one, I spoke about it earlier, because you might not be able to overcome other peripheral factors, for example, weakness or spasticity. But also, there is, again, some suggestions that because the arms have a lower muscle mass, and traditionally with a client with a spinal cord injury, you would potentially be doing upper limb exercise, that because the arms have a lower muscle mass, they might not actually require as much oxygen, which therefore would limit the amount of blood flow then to the arms, which would then mean that your heart doesn't have to work quite as hard to actually deliver that blood flow and that oxygen. So you might not actually be able to get your heart rate up and the cardiovascular output up enough to actually get the benefits that you want from your training. Again, a lot of inconclusive results in a lot of studies. I think probably because a lot of factors are peripheral and because it is too hard to actually get the cardiac output out there. And that's, yeah. So the increases in peak power output in a lot of the studies, they've shown that, for example, in arm ergometry testing, they actually have increases in peak power output in those that have done the intervention. However, there's no substantial increases in the VO2 peak. So what they're basically effectively suggesting is that someone can get stronger and be able to create more force output, but it doesn't necessarily have that much of a central effect on their heart and their cardiovascular system. Yeah. Cool. All right, so let's go into what we can actually do in terms of health professionals working with those with a spinal cord injury. We'll go into the approach taken, or what approach you actually choose to take with a client. We'll go touch on neuroplasticity, because I think it is important in any condition that is neurological. The therapy tools that you can utilize when you're working with individuals in a spinal cord injury, the modifications you can make, and then how you might actually use your training and structure your training. Cool. So with this, basically I've broken it down a little bit into an approach that we take, but I think it kind of gives you a bit of an idea of what approaches you should be taking based on the client goals. So if you're looking there, you've got in the first box, you've got neuro recovery. So this is where your aim is to recover the functions or pathways that were lost or impaired. So for example, if you've lost the ability to contract your quad and you want to get to contract your quad again for whatever reason, whether it be functional or whatever, you're trying to basically recover that function. if you've lost sensation and you're trying to get sensation back, effectively you're trying to recover that. So neurorecovery is basically recovering something that's already been lost. Neurocompensation is improving your function using alternate pathways or patterns. So you're trying to compensate for an insufficiency through other means. So you're not trying to recover what was lost. You're trying to compensate for the fact that something's not there anymore. I now have to regain this function. This is how I'm going to do it. Or this is some strategies that I might implement or my body might implement to be able to achieve that. So I guess prime example is, I'll go into that in a minute, but another example is being a wheelchair user. If you've previously ambulated using walking and locomotion in your life, and suddenly you can't do that, and you're changing the way in which you actually achieve the function of ambulation, that's effectively neurocompensation. You're compensating to allow that function to still occur by using a wheelchair. So wheelchair training, everything like that is going to fall under that umbrella. Utilization is using what has been preserved. So you're working what's already working. So again, I'll go into it in a minute, but it's that stereotypical, you've all seen the pictures of the Fitspo of individuals in a wheelchair doing pull-ups in their wheelchair. And they've completely top heavy, they've got muscles, everything like that. But effectively, they're working what they've already got. There's no aim in that exercise in particular to recover what was lost. They're just using and making the most of what they've already got there working. And then preservation is looking to preserve the integrity of a structure or tissue or to maintain a functional skill. So with that, you're going to look at your maintenance of bone mineral density. You're going to look at your cardiovascular fitness, or you're going to be looking at, shoulder health to make sure that someone can actually continue to use their wheelchair for a long period of time without high risk of injury. So on the first two boxes, so you've got neurorecovery and neurocompensation, they're largely going to be related to neuroplasticity, as a large component is going to be dictated by the ability of the nervous system to change. Just quickly on neuroplasticity. So it's the ability of the brain to form and reorganize synaptic connections, especially in response to learning or experience following injury. So it's basically the brain's ability to change and adapt through experience and learning. It also extends to the nervous system and its ability to adapt. So effectively, you can utilize or try and maximize the ability to create neuroplastic change through Kleiman Jones's principles of neuroplasticity. So anyone that's worked with this kind of field probably has at least encountered this list. So effectively, they're different principles of neuroplasticity that you can utilize in your sessions or utilize with individuals with any changes with their neurological system, but also even those that are completely healthy. The idea is, you're trying to, number one, use it or lose it. If you don't use a pathway, if you don't use a skill, if you don't use a function, you're not going to need it, and your body will just basically get rid of it. It will forget how to do it. Use it and improve it. The more you use it, the better it's going to get, and you can actually build on that and be able to increase your efficiency and your effectiveness in doing it. Specificity, it's going to be related to the task or the function that you're wanting. High repetition is actually really important when you're working on trying to develop neuroplasticity. You want to create change, you need to reinforce the pattern or the movement or the neural pathway as much as possible to make sure that you can actually get that reinforcement through the nervous system. The intensity is going to matter, so you have to have the right intensity to trigger the effect that you need. Time, so how long, how much you actually do. Salience, so the importance of what's actually happening to the client or the individual. So if something's really quite boring and really not motivating, and someone really just doesn't feel like it's going to help them, or they just don't feel engaged, or they're not cognitively, mentally there, it's not going to have a dramatic effect on them. The neural system is not going to change. And I guess that kind of then goes to what I said before, that if you've got the muscular stimulation there, and someone's just sitting there and hoping that it makes an effect, if they're not cognitively engaging, it's not going to have any changes to their neural system overall. Might have a change peripherally, but it's not going to do anything in terms of their ability to actively contract that muscle. Age, Unfortunately, age is something that goes against you over time. The younger you are, the more plastic your brain is, the more capacity your brain has to actually change. And not to say that as you get older, it doesn't have the capacity to change. It's just the neural pathways are quite well wired, and it is really difficult to elicit more change in that. Transference, being able to transfer skills to different environments, different areas, and being able to utilize something in a different context. And then interference is going to be whether other factors are at play that actually might cause you to not develop that pattern. For example, previous movement patterns or something like that could be, kind of not helpful. So as I said before, neuro recovery is trying to restore what's been lost. A lot of it is going to be motor training. So this is, for example, improving the strength of paralyzed muscles. It's going to be largely happening at a neural and cognitive level. And it is going to require a lot of cognitive output for a client. So cognitive output is going to be quite high, and it's going to be necessary because you need to be able to drive the nervous system to create some new neural pathways. But from an outsider perspective, it can actually look a bit different in the sense that you can see very minimal motor output, yet they're putting in a lot of cognitive effort and there's a lot of cognitive output. So someone that is going through this might actually be exhibiting a lot of cognitive fatigue, and therefore a lot of rest might be required and a lot of, breaks. But I guess being mindful that when you're working with someone that is trying to recover, the activation of a muscle that has been lost or paralyzed, the effort they're putting in to contract that muscle is basically going to be all or nothing for the most part. So it might be the equivalent of you doing a 1 RM leg press in terms of physical effort, motor output, and how much you're actually trying in terms of effort. So I guess it's important that, yes, repetitions matter. However, you need to be able to manage the cognitive fatigue element to get meaningful practice in. It often, because of that, does involve aids or assistive devices or therapy tools. For example, your active assistant, your use of stimulation, or your therapy games and tools like you can see in the picture. Neurocompensation. It's restoring function using strategies that compensate for the deficits or losses. So this is going to be your use of assistive devices and aids, for example, your wheelchairs. And it's improving the strength of other muscles that might do the job of the muscles that aren't working well. So it is largely motor relearning or motor learning. And it is going to include things like transfers, mobility training, wheelchair skills. An example of, muscles that aren't working well that you need to kind of compensate for example, in some of your quadriplegics, you're going to have weakness in triceps. You might have a loss of function in your triceps, but in some positions, you can actually fix the hand, use your anterior delt to drive the humerus forward and the long-headed biceps, and adduct to create lockout mechanism, which can replace for the function of tricep extension. So using that to go, okay, well, we don't have triceps, but I've got a pseudo triceps mechanism, and I can work that and actually use that to go, okay, I'm going to strengthen my long-headed biceps. I'm going to strengthen these muscles and strengthen that position for this individual so that they can actually effectively use what they need to be able to perform functions. And then in neurocompensation, your wheelchair technique and your transfer technique, as essentially they're learning a new way to get around in the world and to interact with their environment. So it's a lot of compensation, it's a lot of learning, and it's a lot of, shifting in the mind for individuals. So it is quite challenging, but it is going to require, again, a lot of cognitive effort and a lot of cognitive output. So going into the utilization and the preservation. So utilization is using what works and making it better. Basically the same approach you'd take to healthy pops. You may need to be inventive with your execution, but it's basic progressive resistance training. So it may or may not relate to function. You're going to get some individuals, like the gentleman in the picture, that is a bodybuilder. He wants to improve the strength of his muscles. He might be a paraplegic, can't use his legs, but he wants to improve the strength, improve the physique, everything of the muscles that are actually working. And it's the same as a lot of clients, in healthy pops, they might not necessarily be using something for function, but they want to improve the strength. So I guess it's a similar approach you take with healthy pops, as in theory, you're working with muscle structures that aren't actually impaired or minimally impaired in the first place. It's just the execution of this may look a little bit different to what it would in a healthy pop. And your preservation or protection, it's maintaining the condition of structures. So it's maintaining functional capacity, reducing the risk of ongoing issues, and keeping things as good as they can be. Often it's also related to health-related outcomes. So it's ensuring that the condition remains stable and that further complications don't occur as the person progresses, because typically spinal cord injury is a stable, somewhat condition, but the consequences of those deficits over time may lead to an individual's condition to deteriorate or change. For example, you might want to work on shoulder health to reduce the risk of injury. You might be doing weight bearing and some standing work using frames to maintain the joint integrity or to maintain bone mineral density, or using stim or functional electrical stimulation to reduce the risk of atrophy or, muscle complications, or to improve circulation. So I've just come up with a few examples of what you might potentially do with clients. Give me a sec. And how this relates to, I guess, those principles. So you got James, Asia D, spinal cord injury, level 6. He's quadriplegic, but he ambulates with one person assisting. He's got a sensory loss below the level of the injury, but has decent strength. So with a D, he's going to have manual muscle test that's pretty decent. And he has a loss of hand function and quite a bit of high tone. So his goals: get up off the floor independently, improve walking and balance to reduce his falls risk, improve hand dexterity, and improve strength. So I guess in relation to the goals, the getting up off the floor is going to require a new movement strategy, as well as potentially working on specific strength, for example, a lunge pattern or a squat pattern, to ensure that he can complete the task. So you're looking at your compensation as well as your utilization. So in terms of the compensation, it's going to be lots and lots of reps, trying to get the movement pattern down pat, trying to get his body to be able to do that well and efficiently. But alongside that, it's like, you actually need to have a strength foundation to get that happening. So you need to split it almost into the motor pattern as well as the strength to ensure that it can actually be performed. In terms of the walking, you need to develop other strategies to compensate for the sensory loss, but he might actually recover some sensory loss. It'll involve gait retraining as well as motor relearning. So you're going to be looking at potentially trying to get a bit of recovery as well as compensation. So for example, if there's not as much sensory input to him when he's input to his brain when he's walking, he might have to develop strategies such as really stomping his foot down to increase the amount of stimulation that he experiences, because his feet don't actually provide that for his body. So through vibration, through his body, he might actually be able to, compensate for that loss and actually be able to still walk and have it safer for him. The hand dexterity, a lot of that's going to be a recovery. So you're trying to recover the functions that were lost. You might, throw in there some compensation or some recovery through, external mechanisms. So you might be using some of the new hand tools out there. But it all really just depends on the individual. And improving strength overall is going to be that utilization. So, you're going to be working on your general functional strength training. Another example, Carmen is an Asia C spinal cord injury, level T12. She's a paraplegic, lives independently and drives a modified car. She has hypertension as a comorbidity. Goals: maintain her condition so that if there is a breakthrough in terms of spinal cord injury research, her body's actually in a position to benefit from it. So she's aware that she's not going to be walking around, due to the severity of her injury in the near future. The research and the science is not there yet. But if it is in the future, she hasn't got atrophy. She hasn't got a reduction in bone mineral density that might compromise her ability to benefit from that. So her goal is to minimize the amount of atrophy, maintain the muscle quality, and some activation, working on building muscle strength and reducing the chance of shoulder injury. So again, you might be looking at preserving her condition, so using some gravity eliminated plane exercises to make sure that she can actually work on improving that activation. You might be looking at some lower limb strength and recovery, or you might be looking at some shoulder injury, some shoulder rehab, some prehab to make sure that she can maintain that shoulder integrity over time as she progresses using her wheelchair. So some therapy tools that we can use. We've got a few there. We'll go into each one. But there's lots of things that we can be using, and I think it's important to note that they're tools. They're not the only thing that we should be trying to use each session. We shouldn't just be using one thing and that's it. It's tools for our toolbox, and each thing is going to be appropriate at a different time with a different client, or maybe it's not appropriate. But it's just being mindful that, you know, everything has its place. All right, electrical stimulation. So it can be used to promote motor recovery. You can stimulate the muscle contraction to allow for functional tasks. So example, functional electrical stimulation, or you might be then going, okay, I want someone to perform a sit to stand task. To assist in this task, I'm going to put some stimulation on their quadriceps to assist them to actually stand up to maintain knee extension. And you can actually get more motor unit recruitment and a better muscle contraction than when voluntary when using stim. Again, from what I said before, in order to get neural adaptation, you actually require the cognitive output. So again, there's no point slapping the stim on and hoping that they'll magically be able to contract their quads voluntarily. It's important to have that output. And it can assist in achieving a better active range of motion. For example, if someone can only contract their biceps through partial range of the motion, stim can actually assist them to get to the full range of motion. So working the muscle through its full range whilst having active engagement. So sensory modulation and priming is a tool we can use, using tactile and non-tactile aids or techniques to tap into spinal networks, providing sensory information to the brain. The idea is that it improves body awareness, and it's a primer for the body and brain to accept new movement patterns. So by improving one's awareness to areas such as joints or muscles that were previously absent or hard to detect with their own body schema, it can help to try and improve that, create more awareness around that, and create greater engagement during the exercise. And it can include prior to activity, or you can include it prior to the activity to try and maximize the activity's effectiveness. So as you can see, there is some foot stimulation. There's a lot of neural spinal pathways that start and enter the feet. So they're a really great place to be able to try and stimulate to elicit some degree of aid. And you can see in the other picture that there is a vibration plate with two spiky half balls with someone barefoot on there. So trying to maximize the stimulation to the feet to then potentially work on some standing work or something that involves someone having to be upright where they're using the feet, where they might be able to get some output, or at least they might be able to know where their feet are in space to then get the benefit of that exercise. Standing frames or assistance. So this is a tool we can use to achieve otherwise unachievable positions. So you can get the benefits of standing and loading without the person actually necessarily being able to do it actively themselves without assistance. The assistance to get into a position or a movement that can be essentially facilitate part practice or whole task practice. For example, if someone can stand, but they struggle with the sitting to the stand component, you can actually help to facilitate that middle part to actually get them to do it. So using facilitation or even just assistance can help whole practice, or you can break it down into part practice. And then you can use hoists and harness to reduce the demands of the body in terms of loading and the reduce against gravity. But you can also use that to give a little bit of feedback as to how much weight someone's actually able to place, how much weight they can support, and also what they can actually do when they're in that upright position. Can they stabilize their trunk? Can they actually create movement somewhere else in the body? So devices and equipment. So you can overcome some deficits to enable skill performance. So they can be used to be more isolated or intentional with the exercise. So for example, often there are splints for arms that you can actually use to extend the elbow out, lock it out, and you can actually perform shoulder flexion, shoulder abduction, or whatever movement you want. This eliminates the fact that the bicep kind of tends to contract a little bit, or sometimes people don't have the strength to maintain their elbow in extension. So you can actually be more isolated in targeting the muscles around the shoulder in that exercise using that tool. As well as that, as you can see, you can use things like grip gloves or active hands, as shown, to be able to grip, which allows you to use the rest of the arm and function as per usual without the grip needing to be required from that individual. You're basically supplementing it with the grip glove. So you're aiming to get the maximum possible for the exercise. So if you want to improve someone's ability to transfer, or if you want to improve someone's ability to contract a muscle or whatever, say, for example, if you want to get someone's ability to pull themselves up out of something or pull themselves up off the floor, their grip's a problem in your sessions, instead of directly replicating that, you might be able to go, okay, grip glove, lat pull down. To kind of somewhat replicate, the grip would actually be a limiting factor in the exercise if grip is an issue for them. So you're taking away things that might actually limit them, giving it to them, and then working on what you need to work on. And they can be really simple. For example, as you can see in the picture, you've got a slide sheet. All it's doing is reduce the amount of friction. So that allows that individual to then perform that exercise throughout the range of motion without having too many issues to overcome. Assistive tech. So it can improve engagement and compliance. Different neural pathways can be addressed. For example, you've got lots of different things happening in the VR world. You've got lots of different things happening in conjunction with STIM. You've got your locomotor training robotic aids. They're all quite novel, and there's some amazing stuff out there with really good promise. But I guess the biggest emphasis there is that they're tools and they're meant to supplement or maximize the effectiveness of what you're actually doing itself. So they're not there necessarily to replace it. They're there to supplement. And I think a lot of it still, unfortunately, has a lot of, I guess, improvement to work through, or what's the word? More research is needed. Modifications. So scaling exercise looks very different in a neuro-based population compared to a gym-based healthy population. It's important to be able to scale appropriately and also break down the task or exercise appropriately. So our tendency is to overcomplicate things and to try and make things look really impressive and more interesting, but effectively breaking down the tasks that you're working on into components and then isolating that and working on it is probably more effective than making it look big and impressive. So using equipment or assistance to modify the task to hit the right intensity and also to target the right areas is important. And the positions that you actually use, you can vary the positions to vary the functionality as well as the loading pattern, and it can help to improve the resilience of the tissue to different positions. And the amount of support offered, for example, trunk support can really impact the intensity of the exercise. If someone doesn't have great trunk support and they're collapsed down and their posture is absolutely horrendous, then they're really quite unlikely to be able to get the most out of an exercise using their upper limbs, for example. So you want to try and go, okay, let's try and make sure that we can provide the support we need to offer the opportunity for what we want to happen to happen. So I guess training individuals with spinal cord injury in regards to strength and resistance training. So I guess the goals, both the therapist goals and the client goals, are going to determine your approach to what you're actually doing. So your approach is anything more involving the motor learning component things, or component side of things, or skill acquisition, you're going to need more reps. That's the basics of it. You're trying to create a new pathway. If you go the same way through the woods every single time and you decide, okay, I want to go a different way, your brain's always going to want to deviate back to the same way. You're going to want to use the path that you know. You're going to want to use the path that's familiar to you. What you need to be doing with, particularly with motor learning, is, okay, we need a new pathway, And we need to reinforce that so that you are comfortable with it, you know the way, your brain knows what's happening, and effectively you're laying down a really strong foundation to have a new path to the place you need to go. So again, the approach should dictate the focus and how you program or prescribe exercise. So thinking about potentially load isn't necessarily the right progression in a lot of ways to these type of exercises. So thinking about adding complexity or changing their environment, the context, or adding a cognitive task, this might be a more effective way to progress someone as opposed to just loading. So some of this stuff is going to be more outside of your 3 sets of 10 reps. Prescribing a movement or function as opposed to an exercise. So I think, again, we do kind of get caught in that, how can I get this individual to perform this particular exercise I want them to? Might say, for example, how do I get this client of mine to perform a lat pull down? On the flip side, what you need to potentially do is think about what you're trying to get out of the lat pull down. What muscles are you actually trying to target? Is it the lat pull down you want, or is it lat strength? Is it grip strength? Is it biceps? Whatever it might be, breaking it down to that, and then actually working that individually and in an isolated way potentially. And thinking as well, sometimes you need to work muscles without gravity. So if someone is, on your manual muscle test, a 3 or below, you're not going to get them doing an active bicep curl. So thinking about ways in which you can load someone up that is going to work to the ability of that person at that point. So yeah, Asia impairment scale in your manual muscle test is going to give you a bit of an idea of what's actually possible with that individual. And using, I guess, the PRT principles, using that. So if someone can't do something without gravity, or with gravity, sorry, do it without gravity, loading up in that position, and then eventually they might overcome that to get to the point where they can do it with gravity affecting them. Going back to this, neurorecovery and compensation. The aim is neurorecovery and developing new motor patterns, recovering old motor patterns. Exercise prescription needs to focus on repetition and likely requires more rest. This is where basically you're doing as much as you possibly can with good technique, and that's the important thing, and sufficient rest. And continuing this over time, you set this as the home program, and you should be utilizing the principles of neuroplasticity to help you get the most out of this, as the biggest changes are going to come from the adaptations in the nervous system. Unfortunately, with this kind of training, it's really difficult to come up with timeframes. It's really difficult to come up with predictions of how your therapy is actually going to go, because it doesn't follow what the typical research is. It doesn't follow a nice little path and a nice little A equals B. So it is quite challenging to manage expectations around this with clients as well. So I think just being aware that, you need to be open with clients and actually understand that these things take time. You're trying to find a new way to do things. On the other side, utilization and preservation can follow more your typical progressive resistance training approach. So working with your 8 to 10 reps, or 8 to 12 reps, 3 to 4 sets of 60 to 70% 1 RM, 2 to 3 days a week. Again, you need to consider this may impact the ability of a person to perform their ADLs or activities of daily living after the session. And this also might look very different to what it does in able-bods. So just being mindful that a lot of the time resistance training for able-bods is perceived to be going to the gym, lifting weights, doing whatever might be done. In someone with a spinal cord injury, it can look very, very different, but it still is classified as resistance training. So just being mindful of that. Stretching and mobility. So I guess, as I said before, the evidence of stretching is mixed or insufficient. I guess the biggest thing is to consider why you're using stretching and then decide whether or not you're going to implement it. So to be honest, client comfort can sometimes be enough clinical justification as to why you'll do a stretch. You'd actually benefit a lot from doing a test, stretch, retest to determine whether or not you're actually using your time well. So using that scientific method of going, okay, I'll assess something, implement a stretch, or do whatever I decide to do to stretch something. And then at the end of the session or the end of the week, test it again to see if I've actually made a change or sustained a change. Because if you haven't, what are you doing? You haven't actually achieved anything from the intervention that you've applied. And yeah, again, you can be using a range of motion available for an exercise you're doing. You're stretching to make range of motion available. So for example, a hip flexor stretch for someone who's in a wheelchair and you want to do some standing work. If someone is really quite tight in their hip flexor, it's highly unlikely they're going to be in a good posture standing if you're doing standing work if they're really quite tight in their hip flexor, and it might actually be painful for them. Time spent intensity, again, the literature varies. For those with a sensation, asking them what they're feeling. It's the easiest way to do it, no different to what we would actually experience when we're stretching. With anyone with spasticity, you need to ease into it a little bit more, making sure that you're not going quickly into a stretch or quickly changing. And then for those with high tone, noting that you're going to get probably a soft end feel before you're going to get a hard end feel. So I guess the difference between that is soft end feel is going to be a tissue resistance. Hard end feel is going to be your joint kind of limitation. You're going to be restricted by tone probably more than you are by the actual joint restriction or the joint mobility itself. So ease into it and allow it to lessen over time if possible. I guess the intensity can vary, but the time spent, it's just being mindful that, is it a good use of your time? Is it a good use of the client's time? Can you be doing other things more effectively? Is there a way to be in a stretched position whilst you're doing exercise? So would it be a better use of time, for example, to do a heap of upper limb exercises while in long sitting if you want to stretch the hamstrings? They're going to be in a sustained stretch period for a long time, maybe doing 10 minutes sitting in that position while you're doing, bicep curls, whatever you're doing in upper limb. And then after that 10 minutes, they can come out. But instead of spending 10 minutes stretching as a one focus of the exercise, you effectively done 6 exercises while stretching at the same time for that same period of time. So shifting what you're thinking in terms of, yes, this is a stretch. Am I stretching for the sake of stretching, or am I getting someone in a stretch position whilst doing something that's meaningful? Cardiovascular. So unfortunately, cardiovascular training is a bit more tricky to prescribe as a number of factors impact the testing, monitoring, and prescription. So people with low thoracic and lumbar lesions have normal sympathetic control of the heart. People with complete lesions above T4 have partial loss of supraspinal sympathetic control of the heart. And then people with complete lesions above T1 have complete loss of supraspinal sympathetic control of the heart. For this reason, their maximal heart rate can be as low as 130 beats per minute. So in regards to our traditional cardiovascular training and our intensities that we want to try and hit, 130 beats per minute as a max is not going to be equivalent to us getting up to a heart rate max in a session or a heart rate percent at 160 beats per minute. So if someone's maximal capacity is 130, our aiming to get 70% of heart rate max at 160, 170 is kind of really unrealistic. So cardiovascular health will almost certainly be affected in anyone with a spinal cord injury. And they have a much higher risk of cardiovascular disease and complications. And the respiratory function can be limited. It might actually be more worthwhile for some individuals to do respiratory function training and respiratory training as well as, or in conjunction with, or at the same time as, well, not so much at the same time, but working on respiratory training as well as cardiovascular training, because respiratory muscle function is going to dictate the cardiac output that's available. But if someone's respiratory muscle function is impaired, then you need to be working on those specific muscles and that specific ability. So the diaphragm, if the diaphragm's affected, you're going to have a reduced maximal cardiovascular function, but you want to try and improve this as much as possible, whether it be through improving diaphragm function itself or through other mechanisms. So may need to work at lower threshold for longer to ensure that the weakened muscles can deal with the mechanical and the cardiovascular load. So again, working on your respiratory muscle training as well as your cardiovascular kind of aerobic training is important. The heart rate is not necessarily a good indicator of intensity. So this is where your RPE scales are actually going to be really important. So looking at the equivalent of the RPE scale to the heart rate intensity you're actually wanting to achieve. But I guess in that same kind of thing, letting the client know that RPE for them and what you're looking for as a therapist or an individual working with them is going to be related to their heart and their lungs, not so much maybe muscle fatigue or whatever it might be. We're looking to elicit a response that is for your heart and lungs. If you experience weakness in your arms, that's not really the effect we're going for. We're looking to try and stimulate this system. And then with the type, as with most of our standard guidelines, we're looking at 30 minutes of moderate to vigorous exercise for aerobic exercise 3 times a week. Can be looking typically at your upper limb exercise, but there is some potential to be doing some lower limb sort of stim work. However, how relevant that is to someone's function and how relevant that is to someone's ability to do their daily day is actually questionable. I kind of just went through a bit of an example session just to kind of give an idea of things that you might potentially do to utilize some of the principles and also to, I guess, maximize the outcomes for your clients. So, for example, got a C6 Asia B. The goal of therapy is to improve bed mobility, improve transfer efficiency, and maintain shoulder integrity. So you might start off with 10 minutes of arm ergometry, a bit of intervals, mainly because you're already aware that she already is predisposed to cardiovascular disease purely from the fact that she has a spinal cord injury. And if you look at the level, chances are she's got impaired cardiac function as well. Transfer part practice. So practicing getting the slide board in and out, that's actually quite a difficult part of transfers for some individuals. Weight shifting, actually manipulating the slide board, particularly if you have impaired hand function, is actually quite an important sort of component of it. And then also you've just worked cardiovascularly. You want to try and calm things down a little bit for a minute, work on a task that, requires a bit more mental effort doing that. And, the repetition is going to be important. Rolling practice, so potentially you might use a splint and a weight on the wrist to assist with some momentum to stop the elbow from getting in the way, and to help assisting as well to get through the sticking points so that she can actually complete the whole task or at least part of the task without assistance, but her body is able to work through the whole range with some assistance. From there, you might get her into some splinted shoulder flexion with some weight around her wrist in supine. So you're eliminating bicep, the short-headed bicep. So you're straightening the elbow out, locking it out, lifting up, anterior delt, bicep, lifting up, and working through that to try and work in some isolated strength. And then from there, whilst you've got the splints on, straddle sit. So sitting with your feet out wide, like you see the dancers do, with the splints still on. And you might actually give her a little bit of support around her waist using a gait belt to eliminate the need for her to maintain her posture upright throughout because she has impaired trunk control. From there, you've actually got her sitting in a stretched position for quite a period of time. You might then get her doing some other things, so some trunk control, taking the belt away, so then it challenges that component. And then from there, working on what I spoke about before with the long sitting elbow locks and maybe some hip lifts as well. So from the elbow locking, pushing down, protracting, and then lifting the hips up, which is the skill that is part of the skill that's needed for transfers. And then changing the position up, prone, forearm supported scap protraction. So trying to make sure that the shoulders can actually deal with load, and that she can protract, which is going to be an essential skill that she needs. And then from there, you got your prone forearm support, elbow out to the side, almost like a pseudo push-up and lockout. So this is going to be important again if she ends up prone or transfers into prone to then be able to roll herself back up. So be able to push herself from prone to come into a half roll and then be able to progress into side lying eventually. So I guess this is some different ways that looks very different to your progressive resistance training in healthy pops, but utilizing different ways of loading and progressing in your session to hit the client's goals, as well as making sure that you're maximizing your time efficiently. Cool. So that's pretty much it. I will open it up to any questions if anyone has questions. So go. Yes.
Well, approximately 50% of spinal cord injury develop nerve pain.
Mhm.
So is that how are you dealing with this when you do spinal cord injury rehabilitation?
Yeah, so I'll just repeat the question. So one of the questions was approximately 50% of individuals with spinal cord injury have nerve pain. How do we deal with nerve pain in sessions or just working with individuals? To be perfectly honest, a lot of it is more guided by the medical management they are currently undertaking. So a lot of clients are taking medications that can assist with that. But on the other side of things, it's working within the thresholds at which they actually can work within. So unfortunately, there's not a lot in terms of exercise that can actually change nerve pain, neuropathic pain. But I guess it's working with that individual as to the levels that they're comfortable with working in, as well as making sure that, you know, they can manage things and tolerate things as well.
But from a level, is it hindering? Is it something that then a person would say, no, I don't want to come anymore because my pain is increasing so dramatically?
So the question, the question was, is it something that's then hindering the individual and making them not want to come potentially? I guess it depends again on the individual. Like I think some people actually utilize their neuropathic pain to give them sensory perception. So I know I had one client in particular, she uses her neuropathic pain essentially to give her a map of where her leg is. Yes, it's painful, but she kind of uses it to go, okay, well, this is where my leg is because that's where the pain is. So for some people, it can actually help to drive a bit more, I guess, change and a bit more motivation. But for others, it may be a bit, but I think that's where pain education and medical management and everything like that comes in, because unfortunately exercise can't really change that dramatically, unfortunately.
Also depends on the individual. I find that, after an exercise session, you have a lot of neuropathic pain. It actually improves being able to move their body, distract the brain from the pain signals that are coming from the brain. You'll find at the end of the session, a lot of the time, they feel like a million times better than previous. So that's an important thing to know.
Yeah. So for those that didn't hear that, Amy, one of my colleagues, said that it is also really dependent on the individual, and some individuals actually report that following exercise their neuropathic pain decreases, and so it can actually be of benefit to use the exercise to help to manage the neuropathic pain. But again, it's very individual based.
With neuropathic pain, is it generally more systemic, or is it certain conditions that bring it on? In which case, you could just, like I said, the consideration before, not placing in situations where they'll be listed, or is it just more systemic?
Can you repeat that? Sorry, so I can say it.
Sure. Then, is the neuropathic pain normally more systemic, so it's just always there, always happening, or is it brought on by something more specific that you can then avoid in your setups?
Yeah, so the question was basically, is neuropathic pain more systemic, or is it often environmental or situational based where you can potentially avoid things? I think, to be honest, pain science is actually a really, really challenging thing. So I think, yes, there are peripheral factors that contribute to pain. However, your brain perceives the pain, and neuropathic pain can be slightly different because there are different chemical signals and different signals happening around the body. But it's your brain's ability to perceive them that it's actually that is dictating your experience of pain. So the individual's experience of pain is what they're reporting. What's happening in terms of what's causing the pain, what's happening in terms of where the pain's coming from, can be anything.
If it's okay, I would like
Yeah.
to ask you, because I've been since 20 years researching chronic pain.
Yeah.
So we distinguish between below level pain, and this is always nerve pain, and above level pain. And above level pain is musculoskeletal pain. Below level is nerve pain. And nerve pain is always on. So they have always pain, and then they have flare-ups. So on a scale from 0 to 10, they might have an ongoing pain of 4, and then they have 10 to 20 flare-ups per day. And this could be a flare-up, could be triggered when they move, yeah? But the ongoing pain is not triggered. It's basically there all the time.
There's a baseline, some fun times.
Yeah, exactly.
All right, so we've had a question. Is there a way to do long sitting elbow locks and hip lifts in a community gym with without parallel bars? Yes. So how we often do them, and I can't demonstrate unfortunately, so I'll try and paint a picture with my words. So what we typically do is to get them sitting on the floor, whether they transfer their hoist, whatever it might be, to get them on the floor. Oh, okay, we can do a demonstration. Okay. Yeah.
Sorry.
On the floor.
No, God, no. Okay, so in the long sitting position, so this is what I talked about, long sitting. Short sitting would actually be when you've got a short, I guess, base of support. But long sitting, you're here on the ground or on whatever support you need, and then you're actually, I have incredibly short arms, so this is a terrible example, but basically working on your elbow locks here. So actually trying to drive that adduction and that humeral drive forward with the lockout position. So using your long head biceps and anterior delt here. And then again, I have terrible arm length, and then lifting up here. So I guess on that note, it is important to recognize someone's proportions. So for someone like me who actually doesn't have long arms relative to their trunk, so I actually can't really touch the ground without coming into a position really far forward. For someone that might have longer arms, they can actually quite easily do that. So noting someone's proportions is going to be relevant to whether or not it's a strategy that's effective for them in terms of transfers. But yeah, locking here and then lifting up. Does that answer that question? Oh, hello, we're here. Oh, thanks. Oh. Okay. Okay, no worries, Cam. Is there any other questions? Thank you, Sarah. No, not at the moment. Yes.
We used to see you mention sensory modulation and priming as a technique or a strategy that you use, but as an OT, we do use that a lot.
Yeah.
But what's the evidence base? Is always the question.
Yeah.
Is there more evidence now? Because
Yeah. So the question was referring to the sensory modulation and whether or not there's an evidence base for it. I think in neuro, unfortunately, a lot of things are kind of anecdotal. There's a lot of stuff that can't really be proven in the research because the populations are so diverse, and it's really quite difficult to get 6 quadriplegics, Asia B, C6, whatever, that have the exact same clinical kind of presentation. And I think that, yes, there is some sort of stuff coming out that sensory modulation might be of benefit, but I think it's something that, and I think as an OT, you're probably aware, people use it, it works, but the evidence may or may not really be reflective of that at this point. And it is a really hard thing because sensation is so subjective. And it's the same as, you know, a lot of things, because it's such a subjective experience. And again, with pain, it's someone's interpretation and I guess ability to articulate what's happening that dictates whether or not they're answering certain questions in the correct way for the research. So it is quite challenging in that respect, but I think like we do use it. There are a lot of clients that benefit a great deal from it. There are some clients that don't really respond that well to it. So I think it's very much a clinician skill base that you need to draw from and a tool set that you can use. But I think it very much varies depending on the individual as well as what else is happening with that individual and what degree of injury or whatever else is going on with them. Sorry, thanks. Any other questions?
Well, can I just quickly comment on that one? The thing
Yes.
I think about sensory modulation is it isn't just perceived sensation. When we're talking about sensory modulation, we're talking about every bit of effort input that you can put in the system, which is muscle spindles, which is all of these other things, Golgi tendon responses, temperature firing, all sorts of things, and they have an impact on the spinal cord, the anterior horn cells, and everything else, all the interneurons. So sensory modulation covers everything. And it can be anything.
Yeah.
So it's really valuable.
So basic summary of what just happened there. So Lee, Lee, yeah. So Lee is one of our, I guess, valued contributors to the clinic. So she's a neurophysio, but what she said is that neuromodulation doesn't just encapsulate what happens in terms of perceived sensation. It involves a lot of other mechanisms of the body. For example, the Golgi tendon organs and the stretch reflexes and everything else that's happening at a peripheral level. And so it can be a really valuable tool in order to stimulate areas of the spinal cord, for example, the anterior horn, to create more outcomes. Is that
Totally.
okay?
Into neurons.
Into neurons, yes, that's what Lee says. Cool. Is there any other questions from anyone online? Nope. Okay. I will just hand it over to Kwan again. So thank you all for listening and thank you for your time.
Thank you, everyone. And thank you, Rhianne, for putting all the hard work in that thorough presentation. I think most of our questions were answered in all that, so that was really cool. So thank you again, everyone, for attending our first seminar/webinar. Hope you guys enjoyed it. We'll be sending you guys an email on just a bit of feedback and also a link to our recording as well. And again, I will probably give you Rhianne's email as well if you had any other questions on the presentation. If you good. Hope everyone has a great night, and yeah, we'll hope to see you guys soon. Bye, guys.